What up all my two doctors and doctresses? Welcome to another video at the Tooth Factory. Today we're going to continue the dental pharmacology series with corticosteroids, also known as adrenal hormones. So in order to understand the entire lecture, it's very important to understand the two parts of this terminology. The steroids component represented by the hormones, basically anything that enters the cell, then enters the nucleus, and then affects the DNA to change its genetic composition or influences genetic function to either upregulate or downregulate the genetic function is known as steroids. And in this case, it's the hormones. Hormones from where? Well, adrenal gland. Adrenal gland, which is right here, guys, has three sections. This yellow section is known as the capsule. Then the pink section is the cortex, and then of course the medulla, just like the bone, right? Cortical bone, medullary bone. Similarly, cortex, medulla. Adrenal cortex is the cortical, which means the three types of hormones, and I'm saying types, not the actual hormones, that are glucocorticoid, mineralocorticoid, and androgens. These three types of hormones are produced in the adrenal cortex, as well as known as corticosteroids. Okay, so let's get on with today's lecture. Table of contents, we'll take a look at the anatomy of the adrenal gland and the hormone production, followed by corticosteroid overview. Then glucocorticoids such as cortisol, mineralocorticoids such as aldosterone. Now keep in mind, these both are corticosteroids, but with different functions. So remember this. We have glucocorticoids and mineralocorticoids. Glucocorticoids, glucose, we eat. Okay? Keep that in mind, just a little trick. Mineralocorticoid, minerals, comes in drinks. Just out of curiosity, right? So eat means metabolism. Drink means water. Fair enough? So far so good? Okay. So glucocorticoids have to do with bodily metabolism, growth, intellect, so on and forth. Whereas water has to do with something we like to call as sodium water retention. Keep that in mind, sodium water retention, because this plays a role in the heart for BP. Okay, we'll find out how, just to kind of give you a little boost started for today. And then we'll take a look at therapeutic uses, pharmacokinetics, as well as adverse effects of all corticosteroids, whether they are glucocorticoids or mineralocorticoids. For glucocorticoids, cortisol is major, natural, and then of course mineralocorticoids is aldosterone, natural. And I say natural because there are synthetic versions as well. We'll get that in the later slides. Then a little short note on discontinuation protocol, because again we said synthetic corticosteroids can be given for treatments, but then we have to discontinue them. Otherwise, their therapeutics and pharmacokinetics will go overboard. And remember this rule of thumb, guys, okay? When a molecule comes out of the bloodstream, yes, that's a blood vessel, guys, don't judge me. Okay, when it comes out of the blood vessel, goes into the cell, goes into the nucleus, and then into the DNA, and changes a part of it. You understand how long this takes, guys? It's like you're looking at maybe weeks. Therefore, if you were to stop taking this drug, there will still be some effect continuing until it stops receiving and stops changing the DNA composition. Therefore, the discontinuation protocol is very important. So we'll take a look at that at the end of the lecture, near the end of the lecture, and a little short note on inhibitors of adrenal hormones. In other words, when you're treating an overdose or you're treating a long-term corticosteroid influx, whether natural or synthetic, you want to use inhibitors. Lastly, adrenal insufficiency, and then of course some other diseases that are associated with glucocorticoids and mineralocorticoids, okay? And alert for hydrocortisone, cortisol, these are the same thing, guys. Followed by aldosterone, Catabolism, anabolism, very fun concepts. Cata means to break, ana means to build. Okay. Addison's disease, Cushing syndrome, two of the major conditions we will take a look at today, along with other ones as well. And then deoxycorticosterone, which is a precursor to cortisol. It has both activities. It has mineralocorticoid and glucocorticoid activity. I know I'm throwing a lot of information at you guys, but you can write this down for now in order to know what we're jumping into in the following slides. And then, of course, zones and solones, which is like prednisone, prednisolone, right? Those are active versus inactive molecules. Okay, first things first, location. Well, this is the kidney, right? At the back, near the back, kidney, as well as a superior surface joined by adrenal gland. There is a pair. Now, this is a secretory gland. And secretory means it probably has blood vessels attaching itself to the liver, to the kidney, to the heart, to the basic periphery, everything, right? Everything is associated, but by vessels, not nerves. It's a secretory hormone gland. Adrenal gland located on the superior surface of the kidney has three layers. This pink section is the capsule, followed by this yellow section in this diagram as the cortex, and lastly the medulla. Okay. It consists of secretory, adrenal cortex, and medulla. Medulla produces catecholamines. Now, what is catecholamines? Well, please do check out our general pharmacology lectures up front ahead. But in essence, catecholamines are things like norepinephrine, epinephrine, so on and forth, right? But that's in the medulla, right in the center, right here. Okay, our focus for today, cortex. Glucocorticoids, mineralocorticoids, and adrenal androgens. Now, of course, there are three different types of hormones, three different categories of hormones, right? Anatomically speaking, it has three distinct zones. There's the pattern. Each zone makes a different steroid. It's synthesized from cholesterol. So cholesterol's use in our body is to make steroid, cholesterol, right? Okay. Outermost layer is known as zona glomerulosa. Zona glomerulosa. The middle layer is known as zona fasciculata. Innermost layer is known as zona reticularis. So GFR. Why is this terminology important? Well, first things first, it's located on the top of kidney. And as soon as we hear kidney, we tend to hear glomerular filtration rate. So a way for you to remember this entire scenario is that there are three layers from outside, middle, and inside. And you're looking at glomerulosa for G, fasciculata for F, and reticularis for R. So just an easy way to remember the three layers. Now let's take a look at their functions. First of all, glomerulosa makes mineralocorticoids, which regulates water and salt balance. In other words, sodium, water retention. Okay, so it works on sodium-water cycles. The hormone that acts in this sense is aldosterone. And aldosterone is regulated by a cycle, a system known as Renin-Angiotensin System. Now, I know there's a little bit of a bell and a light bulb going up in our memories, but if you think about it, RAAS, that's the actual system. Renin, angiotensin, aldosterone system. Where did we see this, guys? In the hypertension series, in the lecture for hypertension. So please do check that out as well. Well, however, let's take a look at what that really means. Okay, Renin-Angiotensin system is a system designed to regulate blood pressure. How does blood pressure get regulated? Just a little basic, right? So if there is a decrease in BP, our kidney sends water by salt into blood. Okay, blood increases in blood volume. Blood volume needs to circulate by the heart, so it increases cardiac output. and then of course BP increases. That's the function. Okay, now this section right here, water, sodium. The rule of the thumb is that water follows sodium. So what the kidney does is tells aldosterone, hey aldosterone, please go and get some sodium and put it into the bloodstream. Stop it from going outside of the body in urine and bring it back into blood. Water says, uh-oh, my partner is leaving, I'm going to follow. So water follows sodium into the blood and blood volume goes up. Guess what it causes? Hyperaldosterone use causes increase in blood pressure. Therefore, in other words, if you look at the whole scenario, we'll write it down here so it's easy for you to understand, is aldosteronism equals hypertension. Hopefully that jogged our memory back very easy, guys. So that was zona glomerulosa. Okay. Similarly speaking, we have zona fasciculata. Zona fasciculata makes glucocorticoids, which regulates metabolism and stress response. I'll get rid of this first, guys, here, so it's easy. Okay, and stress response. So what that tells us is, like water following sodium, metabolism follows stress. So what does that mean? Whenever there is stress induced in our body, so in this diagram on the right hand side here, the hypothalamus says, uh-oh, there's stress. Let's increase corticosteroid releasing hormone. This is corticosteroid releasing hormone. It goes up to the anterior pituitary and says, okay, I will release the ACTH. ACTH goes to the adrenal cortex and says, hey, the head office told us you need to produce more hormones. So adrenal gland, the adrenal cortex, is going to be like, what's the reason? What's the reason? Why? Which cause, right? So hypothalamus is going to be like, well, the stress is the cause. So adrenal cortex is like, okay, stress sounds good. Fasciculata, you're up. You're going to increase metabolism. Well, how? By the use of cortisol. That's the story. Cortisol is dependent on circadian rhythm. It's a circadian hormone. What's circadian, guys? Circadian is day and night. So during the day, cortisol is high. During the night, cortisol is less. Why? Because we're not stressed at night. We're sleeping at night. So cortisol is less. But during the day, we're stressed, right? Work stress, school stress, family stress, money stress in the day. Our body needs to be jump started back, for diets, for walking around town and going up and down the staircase and so on. So during the day, cortisol goes up in numbers, up to 300 milligrams. That's how much you can produce inside your body endogenously. Hence, it fights stress by metabolism. So the most common example we look at is basically running. So you went for a run, you put your body through stress. Okay? When you put your body through stress, this whole process goes. And by the way, just a little tip here. This is known as the HPA axis. Okay? HPA. Why axis? Well, because of this entire diagram. It's an axis. So essentially, hypothalamus, pituitary, adrenal gland axis takes the stress, increases cortisol, which increases metabolism. So after the run, we have increase in metabolism and we burn fat. Lipolysis. Guess what a lysis is? Breakdown. What is also known as a breakdown? Catabolism. Okay, great. Now imagine if you put yourself into stress instead of running, you put yourself into stress for weightlifting. So weight training. All right, cortisol goes high. And then what does weight training do? Increases muscle. Muscle growth, guys. Guess what increasing or building muscle is called? Anabolic. Okay, here's the catabolic and anabolic scenario. I know this is very preliminary, but we'll take a look at all the detail in the future slides. Okay, there's of course variation. It's never this black and white, so bear with me here and we'll make it easy for you guys. Okay, lastly, inner layer, zona reticularis. Adrenal androgens which regulate the reproductive system. Of course, androgens are sex hormones such as testosterone. Testosterone is a male sex hormone. The inner two layers are controlled by ACTH and CRH activity. Okay, ACTH is the adrenal corticotropic hormone. This executes action. What execution? Execution planned by corticotropic releasing hormone. Hypothalamus tells pituitary, which then goes to adrenal gland, and action occurs. The synthesis of either aldosterone, cortisol, testosterone occurs. Okay. I'm glad the story is over because the rest of the lecture technically just summarizes itself. So let's go through with it. This is connective tissue capsule. Okay, done. Zona glomerulosa, fasciculata, reticularis. Glomerulosa is mineralocorticoid. Zona fasciculata is glucocorticoid. Reticularis is androgens. Superior surface of the kidney. And that's the adrenal gland. Of course, there's pairs. Okay. Moving on. This is another anatomic and histologic diagram. You can see the difference here. The connective tissue and this large area just up till here is both the area of importance for today, and then the next lecture, adrenal cortex area reticularis as well. And then of course the medulla, which is the core of the entire section right here. So one more time, superior surface, cortex, medulla, adrenal gland. Tissues, glomerulosa, part of the cortex, cortex, GFR. Medulla, not important right now. Okay. Hormones released by glomerulosa, mineralocorticoids regulates minerals balance, known as aldosterone. Fasciculata, glucocorticoids regulates glucose metabolism, known as cortisol. Corticosterone and cortisone are other ways and other parts, other phases of cortisol. Lastly, reticularis is androgen stimulates masculinization, and in this entire word, what we want is the sterone, because there's so many types, right? There's testosterone, for example. Lastly, medulla, something we're not going to worry about, is basically going to release stress hormones for the nervous system, CNS, ANS, and we're talking about epinephrine and norepinephrine. Okay, now we've been well versed with the whole system. So let's dive into the pharmacology of corticosteroids. They're synthesized from cholesterol in the adrenal cortex and then is delivered to the target tissue using bloodstream. They go intracellularly, attach themselves to specific receptors in the cytoplasm in the target tissue. Then there are two major types of receptors that we talk about, specific receptors. There's a glucocorticoid receptor and there's mineralocorticoid receptor. The glucocorticoid receptor is known as cortisol receptor. Mineralocorticoid receptor is known as the aldosterone receptor. Fair enough. Glucocorticoid is located all throughout the body, and mineralocorticoid is located in the excretory system, such as the kidney, sweat glands, also known as sebaceous glands, and salivary glands only. How do you remember that? Very simple. Glucocorticoid, when you work out, you burn the glucose, the fat, the sugar around you. Where is all the fat? Well, everywhere. Your entire body loses fat and gains muscle. So, glucocorticoid located all throughout the body. Minerals, well, they leave the body through three types of liquids. There's urine, there's sweat, and there's saliva. Okay? That's the summary. However, they're both present in the brain as well. Okay, moving on. Once the receptor and hormones form a complex, receptor-hormone complex, they recruit coactivator, which stimulates or a co-repressor, which inhibits. Now, what are we activating and what are we repressing, or also known as inhibiting? We are repressing or activating genes. But wait a second. We went from the bloodstream to the cell's cytoplasm, but the genes are in the nucleus on DNA. Well, how are we going to get there? Well, proteins, which helps the hormone to attach itself to genetic components inside the nucleus via a process known as translocation. So translocation allows this transition from cytoplasm into the nucleus onto the genetic composition. Later, transcription allows the gene to either turn on or turn off, either activate or repress. Fair enough? Great. This mechanism requires some time to be activated because, well, it has to go through so many stages. And it also takes some time to leave the system when discontinued therapeutically. Hence the concept of tapering doses. This is the discontinuation protocol we will talk about in the very end of the lecture. Note that steroids work intracellularly, inside the cell, in the nucleus at genetic level, guys. Glucocorticoid, cortisol. Okay, so glucocorticoid is now, we're moving into the bottleneck, right? We're going into the specifics. We went from the anatomy to the overall hormones into glucocorticoid. Now we're into cortisol itself. It's a principal glucocorticoid. It follows a circadian rhythm. Circadian rhythm is the day and night cycle. And with production, increasing production at diurnal cycles. What's a diurnal cycle? Diurnal is daytime, nocturnal is nighttime, nocturnal. It peaks early morning, followed by a decline, then a short peak late afternoon, and then a further decline at night. Well, think of it this way. When you wake up, you turn your car on, right? Your car heats up. Heating requires energy. Our body works the same way. When we wake up, the CNS wakes up, the circulatory system wakes up, heartbeat goes up. All of that needs energy. So our body has designed a beautiful hormone, a steroid-based hormone, cortisol, that peaks when you wake up, right? And then it declines up until the afternoon because when you drive, you put the car on cruise, right? At the highway, until you come to intercity roads again, and you need more energy to kind of go uphill in the car, or you need maybe a traffic light that came, anything. You need a peak of energy. So there's a shorter peak late afternoon, and then a decline at night because we want to sleep at night. We don't want energy at night, we just want to sleep. So low energy. Okay, it's produced in the zona fasciculata. We went through that last slide. Stimulation of cortisol secretion is done by stress and feedback mechanism. We looked at that as well, how the hypothalamus pituitary adrenal gland axis deals with this entire scenario of stimulation of cortisol from fasciculata. The effects of all glucocorticoids, basic. Now I'm talking very, very generic. Normalizing metabolism promotion, great. Increases stress resistance, sure. Alteration of blood plasma, of course, because we're metabolizing sugar and fats and muscles and so on and forth. But what about this section here? Heavy anti-inflammatory actions. This is something new. Corticosteroids have function as an anti-inflammatory. Now, remember this, NSAIDs are known as non-steroidal. These guys are steroidal. That's why NSAIDs were created, to distinguish anti-inflammatories from steroid base to non-steroid base. All right, so we're back on track with the medications now, right? We're diving from the general physiology into pharmacology now. Okay, normal rate of secretion of hydrocortisone, 10 to 20 milligrams. However, under stress, expect up to 300 milligrams. right? Why? Well, think of it. Your car's going uphill. You're having a tough day, right? You're walking upstairs because the elevator is broken. You're putting your body through a lot of physical stress. That stress needs to be coped, right? Your blood needs to flow, your metabolism needs to go. Otherwise, you're going to collapse. Therefore, this 10 to 20 milligrams goes all the way up to 300 milligrams. That 300 milligrams of cortisol does normalizing metabolism, increasing stress resistance, anti-inflammation, and so on and forth to fight this stress right here. Fair enough? Great. Let's move on to this diagram here. A lipid-soluble steroid, cortisol, diffuses across the border on the cell membrane, so cell membrane, and binds to a cytoplasmic receptor. What cytoplasmic receptor? We're talking about glucocorticoid cortisol receptor. So cortisol comes into the inactivated receptor, sits on the receptor, and then a complex is formed. Complex of what? Either an activator or a repressor, right? Okay. Once all of that is formed, there's something that is known as translocation. Translocation means from the cytoplasm to the nucleus. It goes right through the nucleus. Then this indentation right here finds its space for genetic components of the DNA, and it sits on there. This is called the glucocorticoid response element. Right? It responds. It goes and finds the glucocorticoid and sits on there. Then binding to this glucocorticosteroid response element, it either stimulates or inhibits the activity of an adjacent promoter, which initiates or inhibits the transcription portion of the genetic component. So translocation followed by transcription, right? Not subscription, guys. That's something that I request you guys to do to our channel. Well, very clever, eh? Okay. Sorry, terrible joke. Just trying to keep the class awake. Okay. So after the DNA is processed, mRNA is changed. mRNA change is in amounts of specific proteins, and then those proteins go out into bloodstream and cause biologic effect at target organs. That's the whole story on how it functions. Okay, so let's take a look at the diagram that we made, and this is available in our previous slide as well for the pituitary and the hypothalamus video. This is for cortisol. There's stress and it's daytime. It provides a positive feedback to the hypothalamus in the brain that sends CRH, which is corticotropin releasing hormone. Releasing. It has a function. It releases something. Where? Anterior pituitary. This is posterior. In the anterior pituitary, it says, okay, boss, I'm going to send ACTH. What is ACTH? Which is known as the Adrenal Corticotropic hormone, which then goes into the bloodstream to the kidneys, right over the kidneys at the adrenal gland, not the medulla. Then the cortex accepts it because CRH and ACTH respond to the inner two layers of the cortex only, not medulla. Okay? Correction there. Cortex accepts it, and because it was stress and diurnal related channel, there will be glucocorticoids that are released, not mineralocorticoids, not androgens. Fasciculata releases glucocorticoids, specifically cortisol, and cortisol goes and does increase in protein, breakdown fat, breakdown, increase in gluconeogenesis, anti-inflammatory, whatever needs to happen in order to reduce stress. Okay, once cortisol is out, there's a negative feedback to hypothalamus and says, okay, I'm out, please stop producing more because then that's unnecessary. He's just walking up the stairs. It doesn't need as much as running down the street. Therefore, negative feedback. Okay, moving on. Okay, cortisol, normalizing metabolism promotion. It increases gluconeogenesis, new glucose formation. So increases glucose in the bloodstream. Guess what glucose does? Gives us energy, right? When we're weak, we eat a chocolate bar and we're hyper. That's gluconeogenesis, guys, in the liver. Okay, imagine this, liver. It increases amino acid uptake by the liver and kidneys. It increases protein catabolism and lipolysis. This is breakdown of all material in the body that produces sugar as a byproduct. And then it goes into the bloodstream. Low cortisol equals low blood glucose. Therefore, at night, we have a lower blood glucose than daytime. So low cortisol, low blood glucose. Glucocorticoid insufficiency, so less cortisol, leads to, of course, hypoglycemia. Hypoglycemia can also be lethargic, so less energy. Okay, increasing stress resistance. Increasing in blood glucose levels, energy to combat the strength increases. As well as stress can be from injury, trauma, infection, bleeding, diseases. These are stresses. It increases our energy to fight that stress. Alteration of blood plasma volumes, naturally speaking, it increases hemoglobin, erythrocytes, platelets, polymorphonuclear leukocytes. This is known as PMN cells. However, little discrepancy. It decreases eosinophils, basophils, monocytes, lymphocytes. Okay, so what's the catch here? It increases blood components, but it decreases immunity, which also means that because of this alteration of plasma cells, these white blood cells, which are associated with chronic infection, right? Chronic infection, then corticosteroids actually harm us. Okay, point to be noted. I'm going to write this one more time, guys, okay? Chronic and cortisol are bad together, but acute, such as maybe allergies, right? I'll rewrite this here. Acute, so I'm going to write acute and cortisol is good. Okay, what does that statement mean for us, guys? Think about it. Whenever there is a very simple, say, nose congestion, right? Nose congestion. Then a PMN increase occurs because it thinks there's bacteria, there's foreign body, acute infection. It goes up. Therefore, it has a heavy anti-inflammatory. However, during like cancer or systemic diseases, if you offer corticosteroids, it will work as immunosuppressant. Therefore, during chronic conditions, cortisol is actually not a good sign. So, most important therapeutic effect is anti-inflammatory effect. However, decreasing the macrophage and leukocytes can occur with antigen attacks. Therefore, it inhibits phospholipase A2. Okay, where did that come from? What does phospholipase A have to do with anything? Well, phospholipase A2 is going to be ultimately blocking arachidonic acid. Okay, now I'm just throwing words at you, right? But think of it this way. Remember the NSAIDs lecture. NSAIDs had something known as arachidonic acid. Arachidonic acid produced prostaglandins. Prostaglandins caused inflammation, but if you remember clearly, guys, and if not, please go to the NSAIDs lecture. Arachidonic acid and prostaglandin conversion by COX is inhibited by NSAIDs, right? Do we know what corticosteroid inhibits? It inhibits a step before arachidonic acid, which is phospholipase A2. Of course, we'll take a look at this in more detail in the next slides, but essentially the anti-inflammatory effect comes from this one point right here, which is phospholipase A2, which is blocked. Then it blocks arachidonic acid, hence it depletes the prostaglandins, leukotrienes, both of them. Then comes decrease in histamine release from mast cells and basophils. Mast cells, basophils, immunity-related cells, right? It decreases histamine release, therefore less of rash, less of redness, right? Congestion, and so on and forth is mast cells. Other effects. It increased cortisol is inhibitory feedback for adrenocorticotropic hormone. We looked at that in the previous slide, leading to a decreased glucocorticoid, including a thyroid hormone production as well. So if there is cortisol very, very high, it has an inhibitory effect on the thyroid hormone as well. Okay, just a little side note, nothing significant for this lecture. Adequate levels of cortisol normalizes the glomerular filtration rate in the kidneys as well. So part of the metabolism is post-metabolism, which is excretion. So adequate levels of cortisol also takes care of that. Do we know why we have nocturnal urasis? Nocturnal urasis, which is bedwetting. Bedwetting is because cortisol is out of proportion. Why? I'll give you an example. When a little baby, or a little child for that matter, has seen a horror movie at 10 p.m., right? A very scary movie, and they're extremely afraid of ghosts. Okay? So ghost then goes to bed, then dreams of the ghost. That puts them into stress. Stress leads to increase in cortisol. That's a terrible cortisol, by the way. It's horrific, more than the kids' movie. Okay, so cortisol increases at night. Cortisol leads to increase in GFR, which is glomerular filtration rate, and therefore urine. Ghost equals urine. That's how it works. Okay, just to remember, nothing significant. Okay, moving on to the actual details of all of those actions. Carbohydrate and protein metabolism. There's an increase in glycogen, which is a storage molecule of glucose in the liver, increase in glycogen synthesis, increase in gluconeogenesis. We found out about increase in blood sugar levels, decrease in glucose utilization for target tissues, increase in blood glucose levels, which is hyperglycemia. So are we starting to think that this kind of causes diabetes, guys? Think about it. Diabetes is increase in blood glucose levels. So is increase in corticosteroid, cortisol action. Okay. Increase in protein breakdown, amino acid mobilization to the liver, causing catabolic action of the cortisol. Moving into increased urea production. Increased urea production, as well as adverse reactions such as muscle wasting, right? So we're breaking down protein here. We're doing catabolic action, lympholysis, osteoid loss, bone loss, skin thinning. These are all catabolic actions of cortisol, okay? Catabolic actions of cortisol. Moving on to the next category, fat metabolism. There's an increase in lipolysis, again catabolic. It also not only breaks down the fat, you can't just get rid of fat overnight, but it redistributes the fat into various areas, like the neck. And guess what that causes? A buffalo hump in the face, moon face. Fish mouth around the lips. It decreases subcutaneous fats in peripheral tissues, such as face, neck, and shoulders. So we'll take a look at the picture in the future, but all the fat deposits itself in the neck and then decreases itself from the peripheral tissues like face and neck and shoulders in variant ratios. Therefore, it causes buffalo hump, moon face, fish mouth. So very important for us to remember, buffalo hump, moon face, fish mouth. Corticosteroid side effects. Okay, calcium metabolism. Remember we said osteoid loss? Here it is. It decreases or inhibits intestinal absorption of calcium. It increases renal excretion of calcium. So basically just doesn't like calcium. I don't know why though. Okay, decreased bone is the loss of calcium from the bone, causing osteoporosis. Now we have diagnosis. Vertebrae, ribs are more sensitive to these types of degradation, but osteoporosis is what we take away. Okay, moving on to the next set of actions. Skeletal muscle effects. Hypercorticism or hypocorticism both lead to muscle weakness. Okay, now what are we talking about? We just said cortisol is protein breakdown. How is hypo muscle breakdown? Well, here it is. Hypocortisol, decreased work capacity due to hypodynamic circulation. Hypercorticism is excess mineralocorticoids, which causes something known as hypokalemia, which leads to weakness. Excess glucocorticoids, catabolism. That's something we looked at. Muscle weakness. Myopathy is muscle pain, causing weakness. Okay, one little step back here. Hypocorticism. Hypocorticism is decreasing energy, which means decreasing in work capacity. You know what builds muscle, guys? Lifting weights. Lifting weights requires a high energy and high working capacity. If this is not there and they're reduced, then muscle is also reduced. Therefore, a balance is very, very important when it comes to cortisol. Okay. Cardiovascular effects. Increased myocardial contractility, increased constriction of capillaries, constriction of capillary permeability, increase in blood pressure. Okay, so cortisol increases heart activity. Basic. Adrenal insufficiency is indicated by hypotension or low cardiac output. Simple. Adrenal means the gland that produces cortisol, and insufficiency means reduced cortisol. If cortisol increases heart activity, then adrenal insufficiency reduces cardiac output and causes something known as hypotension. Fair enough? Adrenal insufficiency just came in our lectures on the 12th slide, guys. So keep that in mind. It's coming our way now. Okay. Water excretion. Well, glucocorticoids tend to maintain the GFR. They really don't have loss of water. In fact, they increase excess water load. So if there is increase of water in the system, it actually kind of gets rid of it. However, it's not the same for mineralocorticoids. Mineralocorticoids, they actually increase the water in the blood. So what does that say? It says that mineralocorticoids have a higher effect in the cardiovascular system than cortisol. Right? So remember when we said it's not black and white, but it's kind of overlapping grayish? That's what it is. So mineralocorticoids, cardiovascular effect. Okay? Moving on. This is the large one. Inflammatory, anti-inflammatory, immunologic, allergic reactions, immunosuppressive actions. Okay? So it decreases inflammatory response to injuries. It decreases calor, dolor, rubor, edema, functional lesion, tumor. Okay, what is that? This is first year BDS general pathology terminology. Calor, dolor, rubor, edema, functional lesion, tumor are basic signs of inflammation. Decreased phagocytosis and fibroblastic activity. Decrease in phagocytosis and fibroblastic activity is basically saying decrease in immunologic reactions. Suppression of immunity. Decrease in pain due to inflammation, that has to do with the prostaglandin 2, E2 specifically. Inhibition of arachidonic pathway that leads to the decrease in prostaglandins and leukotriene synthesis. Also TNF alpha, tumor necrosing factor alpha, and cytokines also inhibited. Cortisol blocks annexin. Annexin, this is a new terminology, it is an anti-inflammatory protein. It also reduces that. So it's covering every corner now in order to reduce inflammation. It decreases recruitment of leukocytes with antigen. So now we're directly into the immunity, letting all the bugs come in. This, by the way, is a T cell, killer T cell. It decreases cell-mediated immunity, such as T-mediated cells in organ transplantation cases and autoimmune diseases and therapeutics. In a way, this is a good thing. Why? Because say you got a new kidney. Your body's going to be like, uh-oh, new kidney. I have to reject that kidney. How will it reject? Well, using T cells. T cells will go and fight the new kidney cells. But cortisol or glucocorticoids, hydrocortisone, these will go ahead and decrease that cell-mediated immunity. And therefore, organ transplantation and autoimmune diseases can be dealt with very easily. Relatively, of course. It's a very hard process, guys. And then inhibition of interleukin-1, which has to do with macrophages. And of course, inhibition of T cell proliferation, inhibition of cell-to-cell communication, basic immunity responses reduce. Then comes lymphoid tissue. It increased rate of destruction of lymphoid cells. Lymphoid cells are T cells and B cells. And then in lymphoma, it becomes a palliative treatment because there's cancer. Okay. Stomach. There's increased gastric acid secretion, increased pepsin release. This is release, pepsin release, increased potentiation for peptic ulcers. So in the stomach, everything goes up, right? So cortisol, remember, it tends to burn. It tends to increase the energy. Now the stomach can't handle that much energy because there's a lot of acid being secreted. Therefore, there's peptic ulcers. So one thing in common, guys, one of the most terrible side effects of NSAIDs was peptic ulcer disorders. Corticosteroids are kind of the larger, heavier version of NSAIDs. Can you imagine the type of peptic ulcer they can cause? Just something to think about. Okay. Mineralocorticoids. Glucocorticoids chapter is finally over and I've stopped boring you guys. Okay, mineralocorticoids, aldosterone is the king here. It helps control fluid status, concentration of electrolytes, specifically manages sodium, potassium, water, NAKW. It produced itself in zona glomerulosa, the most outer layer. Aldosterone is a natural mineralocorticoid, which means there is synthetic, right? It starts with F, fludrocortisol. That is the synthetic version of aldosterone. We'll talk about it slightly in the next few slides. Okay. Mechanism of action, similar to glucocorticoids, of course. It works intracellularly, goes into the nucleus, genetic component, and so on. Intracellular cytoplasmic receptors followed by genetic stimulation or inhibition through co-activators or co-repressor complexes. The normal rate of secretion of this one is 0.125 milligrams daily. Only at secretory organs. Which ones? Kidney, saliva, and sweat, which is sebaceous glands. Okay. Location of the action, distal tubules and collecting ducts of the kidney. Why? Because water, sodium, potassium, they tend to leave in the kidney. They excrete themselves out of the body, right? And that's where aldosterone goes and says, no, sodium, you can come with me. Water says, okay, I'll follow my best friend. But potassium can leave the body. Just like water following sodium, potassium is followed by hydrogen ions. Just a fun fact. Why? Because hydrogen is a proton that causes normal pH levels. But if it's lost, the pH is imbalanced, right? Therefore, the adverse effects of elevated aldosterone levels causes alkalosis and hypokalemia. Okay, just a little pathology and a little bit of a general chemistry. pH has to do with acid and base. When hydrogen ions are in the blood or in the solution is more acidic, so 1 to 6 pH. When the hydrogen ion leaves the solution or the blood, it becomes basic, 7.4 to 14. In this case, hydrogen is leaving the body. Therefore, less hydrogen is basic. Basic is alkaline, so alkalosis. And of course, when we lose potassium, which is K, you lose hypokalemia. You make hypokalemia as a condition. Therefore, adverse effects of aldosterone is alkalosis and hypokalemia. Sodium water retention is there, therefore blood volume increases, therefore cardiac output increases, therefore blood pressure increases. Remember when we said that mineralocorticoids have primary action on the heart? That's because of this action right here. Sodium water retention. So what's the function then? Well, the function is it increases reabsorption of sodium, bicarbonates, and water. Okay? Why do you need to use it? In conditions such as hypotension, in order to treat reduction in blood pressure, you want to use sodium water retention. Therefore, water comes in, blood pressure goes up, and problem gets balanced. Okay. Decreasing reabsorption of potassium. Potassium is lost in the urine with hydrogen ions, and sodium is retained with water. All of that leads to edema. There is a rise in the blood pressure. Hypokalemia and alkalosis is also seen. And aldosterone also acts in the GI mucosa at times as well, salivary glands, for sodium retention as well. Perfect? All right. So here's a diagram to explain the whole story that we just went through. Let's take a look. There's dehydration and sodium deficiency, or there is a blood volume loss because of hemorrhage, like a bike accident. That's the stimulus. Blood volume decreases, blood pressure decreases. What does that do? It does one large thing. RAS. Let's take a look. In the juxtaglomerular cells of the kidney, this indication goes and says, hey, the body's losing blood pressure, the blood volume is being lost. An enzyme is released to increase renin. The renin, the most influential in the RAS system, Renin-Angiotensin System, renin, comes into play, and it says to the liver that, hey, make sure angiotensinogen, the inactivated molecule, is ready because I'm coming to activate it. Angiotensinogen gets activated and becomes angiotensin 1. Angiotensin 1 is then sent to the lungs at the head office. Head office says angiotensin 1 can now convert into angiotensin number 2 using the lungs enzyme known as angiotensin converting enzyme. That number 2, angiotensin 2, goes and directly affects vasoconstriction of the arterioles, and blood pressure goes up until it returns to normal. But here's the little side twist here. It also goes to the adrenal cortex. Adrenal cortex, the red thing right here. That red area has one little place called glomerulosa, outer layer. Glomerulosa increases mineralocorticoid activity by the function of aldosterone, and aldosterone goes into the kidney and says, let's increase sodium water and reabsorption from the distal convoluted tubule and the collecting ducts, and increases secretion of potassium as well as hydrogen. They leave in the urine, causing an increase in the blood volume, increase in the cardiac output, and blood pressure and blood volume goes up. Fair enough, guys? Everything is simple so far? Great. And this is kind of a summary of the HPA axis that we introduced earlier. Also, guys, at this point, I do want to add, if you guys think this way is better for me to kind of give you the introduction of a topic that's coming later, please tell me if it works. And if it doesn't work, please also let me know in the comments. Thank you. Okay, hypothalamic pituitary adrenal axis. Stress comes in. Higher centers in the brain tell hypothalamus there's stress. Then hypothalamus tells pituitary using the corticotropin releasing factor or hormone, goes into the anterior pituitary. Anterior pituitary then tells ACTH that please go to the cortex and do your job. What's the job? ACTH goes to angiotensinogen, renin comes into play, angiotensin 1 is produced from angiotensinogen. Angiotensin 1 goes to the lungs, turns into angiotensin number 2, then it goes into the cortex in the outer layer of the glomerulosa and then produces aldosterone, and aldosterone then goes to the kidney distal convoluted tubule and causes sodium water retention to increase the blood pressure during stress. Therefore, when we're stressed, you know how we say, don't worry, otherwise your BP is going to go high. Well, that's the story. That's the mechanism. Perfect? And that's the normal of aldosterone. But what about the hydrocortisone, or also known as cortisol? Same process goes in, but the cortisol is released in order to withstand long-term stress. Okay? And we know how cortisol works as well from the past slides. Okay, so this slide here is basically a list of summary for administration or routes of administration, and then of course other pharmacological details. So let's summarize this chart here. Systemic corticosteroids, very important because there's also topical. This in case is systemic. There's gluco and there's mineralo. Glucocorticoids, they're divided into short acting, intermediate acting, long acting. Short acting can range less than 12 hours, intermediate is 12 to 36, and long-term acting are more than 36 hours. Hydrocortisone, which is basically cortisone, it has equivalent glucocorticoid activity as mineralocorticoid activity, and equivalent dose for anti-inflammatory is 20 milligrams. Okay, this is basic baseline. If you want to compare any of these, it has to be compared to hydrocortisone or cortisol. Okay, perfect. In other words, hydrocortisone is the #1 drug of choice in the terms of cortisol replacement. Okay. Intermediate is prednisolone, methylprednisolone, triamcinolone, and deflazacort. Not so significant. But the other ones are important to remember, guys. In this prednisolone and the triamcinolone family, there's more glucocorticoid activity than there is mineralocorticoid activity. And the equivalent dose are 5 gram, 4 gram, 4 gram. So if you think about it, that 5 grams of prednisolone is equivalent to 20 milligrams of hydrocortisone. What does that mean? That these are potent. That's all it means. Higher potency. They're more potent. Less dose, equal effect. Okay. Moving on to dexamethasone and betamethasone. These are big guns, okay? Long acting. They have a very, very strong glucocorticoid property. 25 times hydrocortisone. Unlike prednisolone, which is only 4 times. 25 times, guys. That's incredible. Therefore, a dose of just 0.75 of dexa and betamethasone can give you a 20 milligram of cortisol effect. So these are highest potency. Right? So we're just linking the dots here. Everything's on the table for us to know for all our exams and our dental practice as well. Moving on to mineralocorticoids. This is DOCA and fludrocortisone important, and aldosterone is a prototype. Aldosterone has some glucocorticoid activity, but not even close to its mineralocorticoid activity. And therefore that ratio is kind of managed, not the same ratio at all, but kind of managed with fludrocortisone. Now, deoxycorticosterone acetate, DOCA, is there, and it has 0 glucocorticoid properties, only 100% mineralocorticoid property. This is also known as salt retaining dose. Okay, so aldosterone is not clinically used because it's endogenous, but fludrocortisone, only 0.2 milligrams, will give us equal effect to what 20 milligrams cortisol would do or aldosterone would do. Okay, and then of course the DOCA, we're looking at is sublingually administered for 2.5 milligrams, not important. It's also important to note down, guys, that the corticosteroids can be given IM, IV, nasal, inhaled, orally, intra-articularly, and then topically as well. So there's different drugs that are in question here. So I'll just highlight a couple for us to know. Betamethasone and triamcinolone hydrocortisone. These are very common for topical purposes for like allergies, right? Anti-inflammatory, guys. Now everything's linking up with us. I'm excited to teach this. This is awesome. Intramuscular, triamcinolone as well. IV, IM, betamethasone, dexamethasone as well, hydrocortisone as well, prednisolone. Inhaled, we have all of the salides and SNIDes. Beclomethasone, fluticasone, triamcinolone. Now these guys are for asthma, also an inflammation of the bronchiolar components. So anti-asthmatic drugs. Oral, we have cortisone, prednisolone, methylprednisolone, dexamethasone. Perfect. Moving on to the list agent summary. So now let's talk about their description. Hydrocortisone or cortisol is, well, primary glucocorticoid with rapid and short lasting action, very simple. Significant mineralocorticoid action as well, 1-to-1 ratio. Prednisolone, 4 times more potent than hydrocortisone, we looked at that. More selective for glucocorticoids with intermediate duration, also in the chart in the previous slide. Used for allergic, autoimmune, inflammatory, malignant diseases, and it's preferred in pregnancy. Therefore, prednisolone is something that's very famous in the family of corticosteroids. Methylprednisolone, slightly more potent, selective than prednisolone. It can be given as pulse therapy. Pulse therapy is like this, dosage. Up and down, up and down, up and down. Not a steady dosage. It's used in active rheumatoid arthritis, again anti-inflammatory, renal transplant, anti or immunosuppressant, pemphigus, autoimmune disorders, immunosuppressant, right? So linking all the dots, guys. Triamcinolone, slightly more potent than prednisolone, and a highly selective glucocorticoid as well. Very, very common for topical, T for topical, T for triamcinolone. Okay. Dexamethasone, very potent, remember 25 times, right? Very potent, highly selective, long-acting glucocorticoid. Marked pituitary adrenal suppression. It suppresses the whole HPA. But no edema, no hypertension. How exciting is that? Therefore, it's used in hospitals for shock, for severe allergic and cerebral edema, and so on. Very, very severe drug. Betamethasone is technically dexamethasone, but it's ideally used primarily for cerebral edema treatment. Not that dentistry is associated with this, but just to kind of know. Fludrocortisone, potent with both glucocorticoid and mineralocorticoid activity, but widely used for the latter. Oral dose 0.1 milligrams, 2 to 7 times per week, depending on the need. Treatment of adrenocortical insufficiency just because of aldosterone loss. So it's a replacement of aldosterone. Okay. These are clinical uses of corticosteroids, guys, and not just this. There's many. So let's go to them one by one. Autoimmune diseases such as SLE, systemic lupus erythematosus, polyarteritis, nodosa, nephrotic syndrome, glomerulonephritis, rheumatic fever, acute gouty arthritis, hemolytic anemia, thrombocytopenia, myasthenia gravis. These are autoimmune disorders. Corticosteroids can be used for this. Which corticosteroids? The ones from the chart. Severe allergic reactions. We're looking at anaphylaxis, angioneurotic edema, so basically the cerebral edema, that area with blood vessels in there. Urticaria, serum sickness. These are severe allergic reactions. Bronchial asthma, remember the inhaled steroids can also be used for, of course, asthma and also pulmonary edema, allergic rhinitis, and aspiration pneumonia, so lung related. Okay, infective diseases, bacterial meningitis, miliary TB, severe lepra. So not always used, right? There's antibiotics for this, but it can be used. Then there is neurological conditions, cerebral edema, remember betamethasone and dexamethasone. Tumors for T cell suppression, such as in lymphomas. Remember that, guys. Bell's palsy, and of course the neurocysticercosis. Not important to know? Don't worry about it. Okay. Malignancies. Acute lymphatic leukemia, Hodgkin's disease, lymphomas. Okay. Moving on to renal transplant, organ transplant, skin allografts. These are foreign objects entering our body to become our own, so we need immune suppression. Substitute therapy for acute and chronic adrenal insufficiency. That's where we can also use corticosteroids, right? Adrenal insufficiency diseases. Congenital adrenal hyperplasia. Basically, there is a hyperplastic adrenal gland that makes a lot of cortisol. And then that cortisol says to the brain that, hey, stop making ACTH. And then all of a sudden, there's a reduction in cortisol. But then this tumor or congenital adrenal hyperplasia ends up making more cortisol. Basically, the balance is gone. That's where corticosteroids can help balance it out again. Okay. Eye diseases, allergic conjunctivitis, iridocyclitis, keratitis, uveitis, retinitis, optic neuritis. Itis, guys, itis is inflammation. That's why there's so many, right? Nephritis, arthritis, there's so many itis. Then there's skin disease, dermatitis. Here we go again. Topical, guess which one? Topical is triamcinolone. Also know other things like dexamethasone, hydrocortisone can be used. Pemphigus vulgaris, systemic. Has to be. It's an autoimmune disorder, guys. Exfoliative dermatitis again. Stevens-Johnson syndrome. Lastly, inflammatory bowel disease, ulcerative colitis. Crohn's disease, also a inflammation of the intestine. Lots of anti-inflammatory actions that NSAIDs fail to treat. Okay. Now, other clinical uses. I said that there's more to this, and we're trying to expand on the adrenal insufficiency area. Okay. So, Addison's disease, very important. What causes Addison's disease? Primary adrenocortical insufficiency. Well, it's the actual dysfunction of the adrenal cortex, therefore lack of response to ACTH. So in the HPA axis, H is okay, P is okay, but this is not. Adrenal gland is not okay. Therefore, it's dysfunctioning. ACTH is there, but there's no response to it. Therefore, in response to that externally, we will administer, well, physicians, not dentists. Okay, guys? So hydrocortisone, identical to cortisol, is the treatment. Failure of the treatment can actually cause death, guys. That's the worst. Then 2/3 of the dose is given in the morning and 1/3 of the dose is given in the afternoon. Why is that? Well, because this is cortisol. It has to mimic cortisol. There's a high peak in the daytime and there's a small peak in the late afternoon. It has to mimic cortisol. That's why, guys. Perfect. We're linking everything. I'm very happy you guys are still here. Hopefully, I'm trying to keep you guys awake. We're almost there, so don't lose me here. Stay with me. Replacement therapy, which is secondary or tertiary adrenocortical insufficiency. What's the cause? It's the defect in the CRH production by hypothalamus or ACTH production in the pituitary. In this case, adrenal gland is okay, but the hypothalamus and pituitary sections are not that great. Therefore, mineralocorticoid synthesis becomes less impaired as glucocorticoid. In this case, what it means is that the adrenocorticotropic hormones, the adrenal gland produces proper mineralocorticoids, no problem. But it has more effect on glucocorticoids. Therefore, we need to administer glucocorticoid, hydrocortisone. Fair enough? Amazing. Diagnosis of Cushing syndrome. So in order to diagnose Cushing syndrome, we need to use corticosteroids. What's the cause? Hypersecretion of glucocorticoids. Hypercorticosolism from excessive release of ACTH from pituitary due to anterior pituitary dysfunction or an adrenal tumor. Okay, what does that mean? So essentially there is a tumor that affects the pituitary gland, anterior pituitary gland, and ACTH is released in exceptionally high number of amounts. That causes a lot of cortisol. What does cortisol do? Cortisol displaces fat. Remember? That gives you a buffalo hump. It's a terrible hump. Buffalo hump. Okay. Buffalo hump is a key sign of Cushing's syndrome. Okay. Well, in diagnosis of it, there is a chronic long-term treatment with high dose of glucocorticoids or a tumor that causes Cushing's syndrome. When it is caused by a treatment, then it's known as iatrogenic. Otherwise, it's just known as hypercorticosolism. Okay. The test for diagnosis is cortisol levels in urine, blood, and saliva are very high. And dexamethasone suppression test can also be done. So normally, when you administer dexamethasone, it suppresses cortisol release. Why? Because of the negative feedback loop that we entered DEXA. Body says, oh, I got some cortisol. Please stop producing ACTH. But if a person has Cushing's syndrome, this will never end. And it just keeps going despite of the negative feedback loop. Therefore, we can diagnose Cushing's syndrome. Okay. Replacement therapy for congenital adrenal hyperplasia. What is that? It's caused by, genetic defect leading to suppression of synthesis of adrenal hormones. So in this case, HPA. HP is okay. Adrenal is bad. Why? Congenital genetic defects. It causes overproduction of androgens in females. Well, why? Well, I thought the adrenal hormones are suppressed, right? Well, think of it this way. If HP is good, it still goes to the adrenal gland. Genetic defect is for the adrenal cortex. What about the other areas than the glomerulosa and fascicular? Those are suppressed. What about the reticularis? Well, in this particular case of CAH, reticularis is hyperactive from these two hypothalamus and pituitary glands hormones, and adrenal gland is suppressed. Therefore, there is an overproduction of androgen in females. The treatment is the suppression of H and P because obviously there's a congenital defect. It's not going to fix overnight. What we need to do is we need to stop these two from acting in the first place. Therefore, androgen release in females, by the way, that's PCOD, guys. Very common and very, very painful to go through as a female. Okay. This is a chart where it shows pharmacokinetics. In terms of the short-acting, long-acting glucocorticoids and mineralocorticoids, all it's trying to show us is anti-inflammatory effect and salt-retaining effect. You can see that glucocorticoids have a lot of anti-inflammatory, especially beta-methazone and dexamethasone. Hydrocortisone has equal glucocorticoid anti-inflammatory and salt-retaining property, whereas the prednisone and prednisolone are 4 times. Methylprednisone is 5 times. Triamcinolone is 5 times. But if you look at the mineralocorticoid, fludrocortisone has some glucocorticoid activity, the anti-inflammatory, but extremely high mineralocorticoid salt-retaining property. Okay. Corticosteroid contraindication. These conditions are aggravated by corticosteroids. However, In life-saving measures, corticosteroids can be used. Remember, there's a balance. It's never black and white. There's gray all the time. Therefore, these are technically not absolute contraindication. These guys are relative contraindication, depending on the benefit and risk ratio, technically. Which condition? Peptic ulcer, diabetes mellitus, hypertension, viral infection, fungal infection, TB, osteoporosis, herpes simplex keratitis, psychosis, epilepsy, congestive heart failure, renal. Full body, guys, full body. But don't use them right off the bat. If you have a patient with TB, our go-to is Pierre. Well, who's Pierre? Well, just a little jog. P-I-E-R are 4 different drugs. Who can tell me what those drugs are in the comments below? I'll reply to them as well. Just a little hint, R is rifampin. Okay, just a little jog. Okay, basically, these are relative contraindications. If there's osteoporosis, please don't use corticosteroids. They will cause osteoporosis. But in a life-threatening, so basically what that means is if a person has chronic renal failure, but it's dying of shock and decrease in blood volume because of a large accident, then of course we'll give corticosteroids because this can be treated after. This will kill the person. Therefore, that's known as relative contraindication. Fair enough? Perfect, guys. So then there's adverse effects. I know we talked about a lot of them, so we can swim through this section. Mineralocorticoids can cause edema, of course, water retention. Hypokalemia, alkalosis, we learned about that previously. Progressive rise in blood pressure, hypertension, and then electrolyte imbalance. But glucocorticoid has a lot more adverse effects. Cushing syndrome. It can lead to round face, narrow mouth, supraclavicular hump, buffalo hump, obesity of the trunk and thin limbs, basically redeposition of fats. Okay, fragile skin, purple striae, generally around the stomach area, easy bruising, telangiectasia. These are vascular conditions. Hirsutism, which is increase in hair growth because it kind of hyperstimulates the hair follicles everywhere. This is again a part of androgen and can be seen in PCOD, guys. Cutaneous atrophy done by topical drug. Hyperglycemia and diabetic precipitation, we saw that as well. Myopathy and muscle wasting, susceptibility to infection, all of that has to do with opportunistic fungal infection. All of that has to do with immunity and protein breakdown of the body. So we can't fight anything, guys. Can't fight infection, can't fight people. I'm kidding. Fighting people is bad. Don't fight people, guys. Okay. Delayed wound healing, peptic ulcerations, osteoporosis, growth retardation in children, so no corticosteroids for children, fetal abnormalities such as clefts, psychiatric disturbances, HPA axis suppression, dose and duration dependent. We learned about a lot of that this lecture, guys. Atrophy of adrenal cortex with synthetic steroids that are needed to treat this condition. Now, it can actually be caused by synthetic steroids as well. So we have to balance it. It leads to adrenal insufficiency, but the acute kind. Okay, so what is acute now? We were just talking about primary, secondary, right? Don't worry. We have a little section on adrenal insufficiency coming up as well. Okay. So adverse effects depicted here, guys, for us. Decreased growth, osteoporosis, increased appetite, which is going to make us obese, essentially. Hypertension, apologies. Peripheral edema, emotional disturbances, increased risk for infection because WBC's chronic is dropped. Glaucoma in the eye, remember the eye conditions we can use corticosteroids for. Then we have distribution of body fat, so big tummy, humpback, tiny limbs. Moon face and small mouth, fish mouth, okay? Increased diabetes risk, hypokalemia, and of course, alkalosis. Beautiful, guys. Thank you for staying with me. You guys are doing a good job. Hopefully the lecture is fun as well. Please let us know in the comments below. Corticosteroids dosage and discontinuation, the short note we were talking about. Dosage, factors that determine dosage are duration of action, intended steroid use, so which steroid, long acting, short acting, so on and forth, and intended administration, which is like inhaled, oral, IV, things like that. HPA axis suppression, basically in this case you need large doses for more than 2 weeks because the whole system, whole axis is broken. Therefore, give steroids alternate days for 2 weeks with larger doses. And this one is specifically prednisolone, just as a side note, guys. Discontinuation. A sudden stoppage in the HPA axis suppression can lead to acute adrenal insufficiency. Now we're back again, acute, right? Sorry about the scratch there. I meant to highlight acute adrenal insufficiency. That's what we are now going to step into. It can be fatal, like instant discontinuation. Therefore, withdrawal symptoms can be exacerbated in condition. Dose must be tapered slowly. Inhibitors, corticosteroid inhibitors. I'm going to take you to this diagram first, you guys. Red cheeks and fat pads known as buffalo hump in the back. You must have seen these in a lot of people, and they have a HPA axis crisis. There's an issue with their hormones, the corticosteroids, cortisol issue in the body. Abdominal stretch marks, they look like this, and they're purple striations. They bruise easily because it's anti-inflammatory as well as immunosuppression. And pendulous abdomen, this is the redeposition of fat just like the buffalo hump back here. And thin arms and legs because all of that fat went up to different areas. Okay. Inhibitors, why? Because we want to prevent this from happening. So ketoconazole, and it's an antifungal, it strongly inhibits the synthesis of cortisol. Treatment for Cushing syndrome. This is Cushing syndrome. Treatment, ketoconazole. Then we have spironolactone. It's an antihypertensive drug. It affects mineralocorticoid receptor. Remember, aldosterone increases blood pressure, spironolactone decreases blood pressure. Antihypertensive. It affects mineralocorticoid receptors. Why? Because it inhibits the reabsorption in the kidneys. Do we know what spironolactone falls under? ARBs. What are ARBs? Aldosterone receptor blocking agents in antihypertensive drugs. Hence, it antagonizes aldosterone and testosterone synthesis. It inhibits the androgen overproduction in hair follicles, therefore it treats hirsutism as well. But there's always a side effect, gynecomastia. But don't worry, there's a better drug out there. This drug binds to mineralocorticoids only, just like this, but no gynecomastia. Fair enough? Okay, here it is, guys. Adrenal insufficiency. Finally, it's here. There's chronic, there's acute. Let's get the acute out of the way first. Why chronic is before acute? Because it's more common. Okay, acute. Immediate treatment needed, large dose of IV hydrocortisone, ringer lactate fluid to balance electrolytes. 100 milligrams of IV hydrocortisone every 8 hours until patient is stable. Then for 5 days post stability, give maintenance dose by tapering mechanism. This is the discontinuation protocol. Give fludrocortisone only after hydrocortisone has reached 50 milligram daily instead of 100 milligram. The taper has reached 50. Then give fludrocortisone. Okay, that's acute. Chronic, also known as Addison's disease, and that makes it simple for us. Characterized by weakness, fatigue, weight loss, hypotension, and hyperpigmentation. This case is because of insufficiency of cortisol, inability to maintain blood glucose during fat metabolism. I'm going to add metabolism here so it's not confusing. Minor injuries and insults can produce acute adrenal insufficiency due to shock. Therefore, the treatment is this. However, for chronic Addison's, the treatment is 20 to 30 milligrams of hydrocortisone daily, supplemented by fludrocortisone at the same time. So that's the difference to keep in mind, you guys. Okay, Addison's disease, bronze pigmentation of the skin. Key point. We'll talk about it in our oral pathology series. There's hypoglycemia, postural hypotension, changes in the body hair distribution, GI issues, weight loss, weakness, right? Adrenal crisis has profound fatigue, dehydration, decrease in blood pressure, renal system shutdown, decrease in sodium, and increase in potassium. It's the exact opposite. Therefore, we need to switch it around. Hence, we need fludrocortisone. Fair enough? Perfect. Adrenocortical hypo or hyper function. Now, these are other conditions, right? So we just talked about adrenal insufficiency. This is another condition. We call it CAH, congenital adrenal hyperplasia. So the defect is in the synthesis of cortisol. In pregnancy prone to this condition, treat the fetus with administration of dexamethasone, the potent, the long-term. Inject the mother and treat CAH. Otherwise, the child is going to have. And what are the symptoms? Not enough control, cortisol release, excess androgen release. Therefore, the genitalia of the fetus will be ambiguous in nature. It'll be atypical in nature. Adrenal crisis. It will, the adrenal insufficiency we were just talking about in the previous slide. Retarded growth, which is altered, shortened growth. Fertility issues in the fetus. Therefore, dexamethasone is really, really good. Then there is a reduced cortisol synthesis. Reduced synthesis of cortisol followed by a compensatory increase in ACTH. If you think about it, if the cortisol is less, what is the brain going to think? The brain's going to think, we need to produce more cortisol. But the brain doesn't realize just yet that this is a congenital issue. It's looking at it as hormonal issue. So it's going to increase ACTH. But during the ACTH increase, there's no cortisol production. So the ACTH is going to go all the way to androgens, not cortisol. Because of course there is a cortisol deficiency. So adrenal becomes very large, hyperplastic, hence congenital adrenal hyperplasia. In absence of cortisol synthesis, ACTH stimulation is driven to androgen, leads to ambiguity, atypicalness of genitalia in female fetuses. Therefore, mineralocorticoid excess is seen with increased deoxycorticosterone, which is a mineralocorticoid activity, leading to water retention, then hypertension and hypokalemia. So all of these are imbalanced now. Therefore, it needs to be treated. How so? Well, we can treat it with IV infusion of oral hydrocortisone or oral fludrocortisone. So I'm going to change this here. IV followed by oral hydrocortisone or oral fludrocortisone. Remember, fludrocortisone does have a 10-point glucocorticoid activity with a ratio of 125-point mineralocorticoid activity as well. Treatment goal is to suppress the excess of this section here. Therefore, androgens can be protected. Okay. Another disease, Cushing syndrome. We went through this a lot, so hopefully by this time you guys are ready with a short note on Cushing syndrome. If not, you can write this down. Etiology. We have bilateral adrenal hyperplasia due to ACTH secreting pituitary adenoma. So it's a tumor. That's the cause. Or due to hyperplasia of adrenal gland itself, or ectopic production of ACTH causing hyperplasia of the adrenal gland because of tumors. Okay? It is actually going to have a large, round, plethoric face. Trunk obesity is seen. Myopathy, muscle wasting, thinning, purple striae. easy bruising of the skin, wound healing and osteoporosis, mental disturbances, hypertension, diabetes. The treatment, however, is surgical excision of the ACTH or cortisol producing tumor, radiation for pituitary tumor itself, or resection of both or one of the adrenal glands. And that's severe, guys. It's very, very, very severe. Medications, large dose of cortisol during the surgery, up to 300 milligrams of hydrocortisone IV infusion on the day of surgery can be given, followed by discontinuation protocol, tapering doses. Lastly, this is something that we don't traditionally always talk about, but Croesus syndrome, it's rare, sporadic or familiar genetic condition. HPA acts as hyperfunction, again, same thing. It compensates for the defect in the generalized glucocorticoid resistance. So, HPA is good. It goes to organs, and the intracellular receptors inside, they deny the access. Hence, all of this goes in hyperfunction. Therefore, ACTH increases cortisol, increases other mineralocorticoids and androgen activity, increases. This hyperandrogenism leads to precocious puberty in children, early puberty, acne, hirsutism, male pattern baldness, loss of hair, and menstrual irregularities, as well as hypofertility. And that's the effects of a lot of manifestations of PCOS. The treatment is high dose of dexamethasone and, of course, discontinuation protocol, tapered later. Thank you for staying with me so much, guys. We're almost there. Only one more slide left after this. Adrenocortical hypo or hyperfunction's last session here is aldosteronism. Primary aldosteronism is caused by excessive production of aldosterone by the adrenal adenoma. Again, a tumor, but this time it's located in the adrenal glands. Other causes, hyperplastic gland or malignancy. So cancer, tumor, hyperplastic gland. Very, very common causes. Clinical findings, hypertension because aldosteronism, increase in aldosterone. Hypertension, weakness, tetany, hypokalemia, remember, reduction in potassium, alkalosis, reduction in hydrogen ions, hypernatremia, sodium water retention, excess secretion of mineralocorticoids as well. While secondary aldosteronism is basically resulting in low angiotensin number 2 and low plasma renin. Therefore, it's treated with fludrocortisone 0.2 milligram daily to get this cycle, the RAS cycle that is disturbed, back on track in an oral dosage for 3 days of fludrocortisone. Now, general note that detected by increased ratio of plasma aldosterone to renin. So aldosterone to renin ratio increases, then we have detection of aldosteronism. That's the key point. If aldosterone goes up as compared to renin, then we have aldosteronism. Treated by spironolactone. Remember, aldosterone causes hypertension. Spironolactone is an aldosterone receptor blocking agent. Therefore, the treatment is ARB agent. Okay. And lastly, this chart I will leave here for a summary for you guys to write in your notes. But essentially, it's a big summary from our references of all that we just talked about, right? So adrenal insufficiency, the crisis pathway of events, right? So adrenal glands, defective production of glucocorticoids or mineralocorticoids. Glucocorticoid is cortisol, impaired or no production. If it's impaired, liver function will decrease, hypoglycemia will occur, seizures, convulsions, and lack of consciousness, loss of consciousness leading to shock, brain coma, organ failure, and death. Whereas cortisol's no production at all causes nausea, vomiting, diarrhea, cramps, right? The full body is breaking down. Low body fluid volume, low blood pressure, still causes shock, brain coma, organ failure, and death. That is adrenal glands crisis. Okay. Mineralocorticoids, aldosterone, impaired or no production, doesn't matter. But if the kidneys affected, there's water and sodium loss, right? If there's lack of aldosterone. Hyponatremia, so low sodium in the blood. Hyperkalemia, increased potassium in the blood, exact opposite, right? Heart, because of this increase in potassium, has irregular output leading to cardiac arrest. That leads to death, right? So here's the summary for it, you guys. These are our references for today. We have chosen Pharmacology from Lippincott and the Hall Physiology textbook. Thank you for staying with us for so long, and you guys are doing great. Please tell us if we need to improve on anything, and we'd love to be a part of your family as you are for us. Thank you for watching us. Please like, share, and subscribe so we can understand that you guys are loving the lectures, and please stay put for watching more lectures at the Tooth Factory. Have a great day.